Hi, thanks for joining us. I'm Chris Wallis here at SUO 2023, joined by Dr. Bishoy Faltas, and he just presented some of his great work on the genetics of upper tract disease at this morning's plenary session. So we're really pleased to have him today to sort of guide us through the work he's done and what we've learned. And so thanks again for joining us, and maybe give us a bit of a background on the work you've been doing in understanding the sort of genetic evolution of upper tract disease.
Thank you so much, Chris. I really appreciate this. It's good to be with you. And so over the past few years, we've learned a lot about the biology of upper tract urothelial cancer in general, but one of my areas of interest, as you mentioned, is understanding the evolution of primary to metastatic disease, that's for bladder cancer, upper tract disease, and also understanding the distinctions between upper tract and lower tract disease. And a few years ago, we knew that they were sort of different. They have different anatomical aspects in terms of staging and so on. They have different embryologic origins. But how does that really translate to different biology? And we published a study back in 2019 where we described very clearly that upper tract urothelial cancers are predominantly luminal papillary and predominantly T-cell depleted, or have a T-cell depleted immune contexture, and that seemed at the time to be mostly coordinated by FGFR3. And what we're very happy to see over the past few years is that these distinctions, so we predicted, are panning out in clinical trial data. So we predicted at the time that FGFR3 inhibition would be particularly effective for patients with upper tract urothelial cancer. We're starting to see that in the Thor cohort 1 data that I presented today, and also the the T-cell depleted immune contexture. What does that translate to? That's slightly less clear, but nevertheless, we have data from several studies. So for the Thor cohort 2 data, which was a comparison between erdafitinib and pembrolizumab, you see that there was no difference. The confidence intervals on the first plot were crossing 1, but for the adjuvant studies, for the Checkmate nivolumab study, there was less benefit with upper tract urothelial cancer, which again confirms the predictions that we made back in 2019. One of the things that we're interested in understanding with the recent work that I described that's accepted for publication and the preprint is out there, is the differences between the primary and metastatic disease, or the evolution of these molecular subtypes. So we knew that was the case in the primary tumors, which was our 2019 paper, but how does that evolve over time? And it was very interesting to see that those molecular subtypes, the luminal papillary and the T-cell depleted contextures, are actually stable over time. And if you think about it, biologically, that's actually quite amazing, because that suggests that these are intrinsic properties of the cancer cells. These are cancer cell autonomous effects that are, in some ways independent of the tumor immune microenvironment, because, that cancer cell metastasizes from the upper tract, from the renal pelvis or the ureter, to the lung or the liver, and it continues to be luminal papillary and T-cell depleted. So that is, we think, is mostly a function of cancer cell autonomous signaling mediated through FGFR3. The role of PPAR gamma is actually quite interesting as well, and the link between FGFR3 and PPAR gamma are aspects that we and others are very interested in exploring.
Absolutely. Thank you so much for that background. And I think as you alluded to, the data in FGFR inhibition really is in the metastatic space right now. So I guess the next obvious step is, you demonstrated, and maybe it's logical, therefore, that you do see that stability that you just alluded to, because we know that the FGFR targeting in the metastatic disease is beneficial. So where does this evolve? Where is it coming in the localized disease potentially? Are we thinking, neoadjuvant or adjuvant settings? Or how do we take, your understanding of the disease biology and tailor the therapies that urologists can deliver as a result?
Yeah, that's a great question. And I think, as we start with just the way drug development works is that we start in a metastatic setting, and then we try to move this back to earlier and earlier settings. But I completely agree with you. I think there's very solid biological rationale now that we've seen, that we've described, others have described. It's panning out in these phase 3 studies, and I think in metastatic samples, and again, as you said, that makes sense that there is that stability, because if there was a lot of heterogeneity, then we probably wouldn't see these responses in the metastatic setting. So that's definitely an excellent point. I think there definitely is a role for FGFR3 targeted therapy. And again, maybe with a combination of an immune checkpoint inhibitor, maybe sequentially. So maybe we have to figure out is it a combination, or is it really a sequential treatment that would really prime the tumor immune microenvironment to respond by FGFR3 inhibition, that would prime it to a response to immune checkpoint inhibition. And maybe that's really the optimal sequence for getting this sort of maximal synergy between the reversing the luminal papillary and reversing the T-cell depleted phenotype. I think, moving this to a neoadjuvant setting is always, and window of opportunity setting is always attractive, because you can then have tissue after treatment, before and after treatment, and you can really get a very nice longitudinal comparison between the pre and the post treatment tissues, and try to understand the drug target engagement and the downstream signaling effects in the tumor and also in the microenvironment, and also obviously see the clinical responses. So I think that's definitely something that I think we are evolving towards developing trials with FGFR3 inhibitors in that space.
And when we think about the advanced space, we do FGFR testing to look at whether patients are eligible for therapy. Where are we at in terms of upper tract disease? Is this something, should we be doing this routinely on our ureteroscopic biopsy specimens? Should we be thinking about this when we look at our nephro-U resections? Is this genetic testing something that you think needs to be sort of mainstreamed at this point in time? Or is it so ubiquitous that we can imply it?
Yeah. No, I think this is also another great question. So I think it is definitely predominant, but interestingly, when we looked initially in our initial cohort, so there's definitely a higher rate of genomic alterations in FGFR3 mutations and fusions. That being said, we did see that this luminal papillary and T-cell depleted phenotype in upper tracts extends beyond the cases that had a documented genetic alteration in FGFR3. So we think that actually, particularly in upper tract, that expression levels of FGFR3, independent of an activating fusion or an activating mutation like S249C or other mutations or other hotspot mutations, can still lead to the same downstream phenotype with luminal papillary T-cell depletion. So if I were to pick a biomarker, I think the genetic testing of FGFR3 alteration is definitely the one that is approved right now and the one that we use. But from a biological understanding perspective, I think looking at mRNA expression of FGFR3 potentially has a role. My colleague, Dr. Sternberg at Weill Cornell, has actually conducted a study that's published in JCO looking at with other FGFR3 with FGFR3 inhibitors, looking at whether patients can be treated based on the mRNA expression of FGFR3, and that's an interesting, definitely an interesting concept. And there were some issues with how to test for FGFR3 mRNA expression, but that's something that we need to work more on trying to understand and standardize. Could be a little bit more tricky than a genetic alteration.
Thank you so much. That's a really great synopsis. What do you see as the sort of next step? What's the thing that urologists should be looking out for as we move to sort of better understand upper tract disease and target our therapies appropriately within our patients?
Yeah, so there's definitely, I think you've heard about it today in this session, there's definitely a lot of excitement about circulating tumor DNA as a marker. So I love Roger Lee's work, and we were collaborated with Roger on that, on using circulating tumor DNA to try to differentiate between invasive and non-invasive upper tract. I think that's a very clever use of that technology. Urine ctDNA also has an excellent role, and Philip Babash Fox Chase has done a lot of work in this area, and we're collaborating in this as well. So I think there are lots, they're both urologists urologists. So there's a lot of very interesting work in the circulating tumor DNA and urine cfDNA area, and I think that will continue to evolve further. I think we need to understand how these tests perform clinically before we sort of, go into the, acting on them in terms of clinical trials so quickly. I think that it's important to understand the performance characteristics of different types of ctDNA and urine DNA tests, and also how they perform in different disease settings, upper tract versus lower tract. Patients with bladder preservation versus metastatic setting or more advanced settings. So I think all of these points need to be well characterized before we move on to trials.
Wonderful. Well, thank you so much for your time. Really appreciate you joining us.
Thank you.
Thanks.
Great.